So thank you very much, Rishikesh, and all of my friends in India. I'm speaking to you now from Canada, and in fact, it's early in the morning in our time. So I'm happy to be here at your international summit to talk about surgical techniques to counter postpartum hemorrhage. And in view of the theme of this conference, I think that it's very important that we also recognize that there are many aspects of healthcare for women where there are inequities, and we need to address these in many ways. This was last December when we were here, and my wife and I really enjoyed India, especially traveling around to experience the fantastic culinary opportunities. So I'm to talk about postpartum hemorrhage. And part of that surgical fellowship is really, we also have a team within that we've trained to be able to deal with some of these really complex surgical issues in obstetrics. But PPH is still the leading cause of maternal mortality around the world, at least 1/3 of maternal deaths, and 60% of maternal deaths in developing countries. And the majority of these deaths occur within 4 hours of delivery. And it's important for us in Canada not to be smug about this. We've had a recent maternal death in one of our largest cities in Canada. And so this is something that we need to remind all practitioners of obstetrical care that it is a very significant issue around the world. And just remember the classification, the T's, tonus, tissue, trauma, and thrombin. But often it's a combination of these that result in the problem of postpartum hemorrhage. And management really does involve an interprofessional approach a lot of the times in the post delivery phase. The nurses are looking after these patients, and we all need to be acutely aware of how to accurately assess blood loss and fluid placement and the control at the source of the bleeding. So what are the risk factors? And here's the issue. You mentioned about ultrasound. The three most important things in the last 40 years in our specialty is number one, ultrasound, number two, ultrasound, and number three, ultrasound. The reality of it is that better quality and high quality availability of ultrasound is critical for this particular issue because many of these things are predictable. So if somebody has had a retained placenta, maternal or obesity is a huge issue in North America. Older maternal age, the majority of patients in Canada are delivering after the age of 30 now. Maternal anemia, and it's obviously a huge issue both in gynecology as well as in obstetrics, but twice the risk if the patient is anemia, and obviously the risk of requiring more blood transfusions. Multiple prior cesarean sections. So around the world, we have an epidemic of cesarean sections, certainly in Canada, with rates in the low 30%. And here's the thing, with multiple prior cesarean sections and or placenta previa, we have increased incidence of placenta accreta syndrome. So this is why I've developed a team to respond to this in our level 3 unit. But today we need to talk about, well, what's happening in the rural areas. And this, of course, is very important in India and extremely important in Canada because we have a very large country and multiple small obstetrical centers that don't have large blood banks, and they don't have the ability to have a lot of these high risk tools to be able to diagnose and to predict. And so the ability to transfer patients is limited as well. So many of these are predictable with a high index of clinical suspicion, but by also high quality ultrasound, especially the placenta accreta syndrome. So in these risk factors, we need to be asking for our sonologists, if they're obstetricians and or radiologists, to be able to be looking for these issues. And the reasons for delay in appropriate management is simply underestimation of blood loss in both volume and the rapidity of loss. And patients initially can compensate well for the losses if they're younger patients in good health. And also the hypervolemia of pregnancy allows them to tolerate significant blood loss without significant change yet in their vital signs, and also a delay in diagnosis of coagulopathy. So I've had a lot of, shall I say, discussions or arguments with our anesthesia colleagues about getting coagulation results before they treat. But really, what I teach our residents is that if you're thinking about coagulopathy, you need to start thinking about getting the blood products. And also taking a red top tube and just holding it in your pocket and waiting. If it does not coagulate, you know you've got a dilutional coagulopathy or DIC. And remember, pressure is our friend. Whatever source, we can diminish bleeding by proper use of our hands and other instruments to be able to decrease blood flow, as we'll touch upon. And here's the other one. So even if you have a patient who is on pressors and is hypotensive, don't forget that we can press on the aorta, and I've done this a number of times to allow us to wait for the blood products to get there and to improve the blood flow. And also the use of mask pants if we're going to be considering transfer of patients is something that we need to have available. So for our hospital and a larger hospital, and I recognize that hospitals are going to be different, but we need to, in terms of their personnel. But larger tertiary care hospitals really need to have a massive obstetrical protocol, as do all hospitals, but we don't often have all of these people to be able to facilitate this process. So we need to do this in advance, and we need to do simulation techniques to be able to make sure that we know where all the appropriate things are, all the appropriate instruments that are going to be needed. But as soon as we call this, an OR is on standby. Resuscitation with large bore IVs, packed cells, coagulation screen, all the rest of the other things, and obviously fluid replacement with lactated ringers and normal saline, and then transfusion. And then coagulation factors and all of the tests that we would normally do for this. And certainly platelets become necessary if we've had multiple transfusions and if their platelets are less than 50,000. And evaluate the response by vital signs, urine output, CBC, coagulation tests to guide therapy. But again, the remedy for the cause of bleeding can very rapidly become surgery. And remember that coagulation and coagulopathy is often a clinical diagnosis. And don't let your anesthesiologist or anyone else delay the ordering of blood products on the basis of waiting for tests. The other thing we have are cell salvage systems. Now, we utilize these for those cases that are picked up by ultrasounds of placenta previa, placenta praecreta syndrome, and we know that we can recirculate the patient's blood Once we've delivered the baby and we've gotten rid of all of the amniotic fluid, then we switch over to the cell salvage system. Now, clearly, this is not going to be available across the board in all countries, but it really should be in tertiary referral centers. And we should be picking up these cases so that they don't have to be transferred to those referral centers, and picking them up by understanding that multiple C-sections increase the risk of placenta accreta syndrome in combination with the existence of placenta previa. So these are our guidelines that surgical intervention is recommended if conservative measures fail. And obviously, these are all the medical treatments that I'm not going to talk about, but compression, sutures, uterine artery ligation, hypogastric artery ligation, or what we call usually internal iliac artery ligation, as well as hysterectomy. We try to avoid subtotal hysterectomy. I have techniques to be able to figure out in a fully dilated cervix where the end of the cervix is, but that's another discussion. And for women experiencing PPH and awaiting transfer, bimanual uterine compression or even external aortic compression may be done, and the use again of non-pneumatic anti-shock garments. So by the time our team get there, most of these techniques using B-Lynch, and occasionally people are trying to get the uterine arteries, but all the different techniques, at least in our experience, have been less than satisfactory for control. Others may have better techniques. The other thing to think about are bulldog vascular clips, which we can use at the uterovarian ligament, and occasionally for open surgery for the uterine vasculature. But the problem is that we do see cases where people have tried to get the uterine vasculature, but due to the proximity of the ureter, they get damage to the ureter. So the solution to this is we don't recommend getting the uterine artery close to the uterus. We need to go into the retroperitoneal space, identify the internal iliac artery, the origin of the uterine artery, and getting it there. If you're into that space and you can do it, it's actually better to do bilateral internal iliac artery ligation due to the multiple collateral blood flow that will continue the bleeding. So basically, the clips at the uterine, the ligament of the ovary, uterine origin, and ideally, my bias is to do the internal iliac artery, which we'll see in a second. This is a technique. This diagram shows the traditional way of utilizing silk ties. This has the risk of damaging the veins behind the artery. So we recommend a different technique that was taught to me by a trauma surgeon in the Canadian Armed Forces who had worked in Afghanistan during that unfortunate activity there. And in their when they were dealing with pelvic bleeding in any patients, males or females, they would do an internal iliac artery ligation using large vascular clips. So he taught me that. It's much faster than the old technique. And I'll just show you this if it'll work. There we go. So this is on the right side of the patient, and you can see the ureter, the external iliac artery, and the internal iliac artery. So here we've already opened up the peritoneum, parallel to the infundibulopelvic ligament. Then you isolate the internal iliac artery. And we use Lowers to develop the spaces just on either side of the vessel, and usually about 2 centimeters from the bifurcation of the external and the internal, and holding the ureter, as you can see with the Yonker suction, away from where we're going to put the clips. And this is not a difficult procedure. It just takes practice to get into these spaces and to understand them. So here we use the contemporary clipping technique. And we use, excuse me, 2 large vascular clips. And you can see in the bottom, this is a case of placenta percreta, and there's a very large bulging out placenta. So these are the ones that bleed very significantly. And here we go. We've completed that procedure. And here's one. We got called just last week for a major bleed that was unrecognized and had been transferred. And here you can see on the right-hand side, the hand holding the uterus. And what I'm doing is showing exactly where the vessels are. So just this is a little bit more difficult to see than an animated one, but you can see it's the same technique. And there we go. And we use 2, and you have to do it bilaterally, just simply because of the collateral circulation in the female pelvis is absolutely amazing. And in fact, even if you're not doing a hysterectomy, this does not impact on a woman's fertility for the future. So the other thing that I've been taught by trauma surgeon is damage control. This is really the concept where if there's traumatic injury or bleeding due excessive bleeding and dilutional coagulopathy or disseminated intravascular coagulopathy and continued bleeding, it leads to hypoperfusion, acidosis, and exposure with an open surgery for a long period of time can lead to hypothermia. So unless we correct all of these things, the patient is going to die because she will not have an adequate response to even repletion of blood products and coagulation factors, because if they're cold, they won't work. And here we have damage control concept overall. So dilution of coagulation factors, hypothermia, acidosis, hypocalcemia lead to coagulopathy, which continues the acute hemorrhage, even though we're giving transfusions, IV fluids, as well as blood products, as well as hypoxia. So this is a massive, terrible cycle that patients get into that lead to death. So damage control can be utilized for transfer. And what is that? So in this situation, what we have to do is put pressure on the bleeding sites. So at laparotomy, multiple sponges, green towels, and closure of the abdomen or non-closure, and just utilizing special issues with pulling the tissues together can actually save the patient's life, because if you can stop the bleeding with the pressure, warm the patient, and then give all the blood products, or even transfer the patient to a tertiary care center where blood products are more readily available, this can save the life. So pelvic packing is the key to this process. And this is what they do in these war-torn areas. And they pack and they put the patient in the ICU and they re-warm them and get the blood products in when they're warm and to save their lives. So at the end of the day, with postpartum hemorrhage, if they're not controlled by the usual medical and pelvic examination and pressure, then we need to move to surgery. And in conclusion, blood loss is consistently underestimated. And this can result in inadequate treatment, resulting in the complications or death. And as I say, even in a large center in Canada, this can happen just simply because people are not watching and are underestimating the blood loss. A trickle can be enough over an hour or two. And pregnancy anemia and other underlying health conditions can profoundly affect a woman's ability to tolerate any blood loss. So, and remember, all of those predictable risk factors can be determined in advance. And if you need to send the patient in advance to a center where there is a much better blood bank and many more people to be able to look after these patients, these very high-risk patients who are placenta accreta syndrome need to be transferred. So, and most of the time in places around the world now, in Europe and in the United States, it's that it wasn't picked up early enough and they're in a small center and weren't able to keep up with the blood loss. So damage control is a very important concept and may save a life. And ultimately, we need to train all healthcare providers providing maternity care should learn all of these life-saving surgical skills as well as other techniques. Systematic pelvic devascularization is a good way to conserve the uterus and to control PPH. And again, we are now training all of our residents to go out into practice with these skills, but they need to practice them. And we often have simulation models that people can utilize. So we must, and in keeping with the theme of this particular conference, reduce maternal deaths to promote safe motherhood around the world. Motherhood and mothers need to be saved in this way, and we all need to recognize that there are lots that we can do to convince governments and hospitals to provide these appropriate instrumentations and better ultrasound, etc., to improve our care and reduce maternal deaths. Now, that's a whirlwind view of this, but in fact, I think the important concepts are here. But again, thank you very much. And my wife and I, again, had a wonderful time in India, and we look forward at some point to coming back to your wonderful country.
Thank you, Dr. Nicholas. That was really a fantastic talk. And I think, the one aspect which you stressed on, uh, this particular surgery should be taught to each and every gynecologist, because I think it's life. It's really, really important that this skill is updated to each and every person who does deliveries, and very, very important. In India, we have the FIGO project, FOGSI FIGO project, which is PPH Ampli. And as you said, damage control, before we reach the damage, I mean, if we are teaching our gynecologists about carbetocin, tranexamic acid, and misoprostol. In fact, those who deliver at home are actually given misoprostol, so that if they find that the bleeding is more, they can self-administer those drugs. because it's like you talked about smaller centers where it's not possible to do tertiary care or the surgeries. One question I wanted to ask you, because obviously all of us are working in tertiary care centers also. Is there any comparison between the surgical ligation and maybe, uterine artery embolization or those kind of where we use, like I did a cesarean, we put a balloon, and block, it was the
Yes.
placenta accreta. We put in a balloon and then we left it. We released the balloon. There was no bleeding. So we came out and gave a methotrexate. But do you have any comparative studies on these things?
Yes, in fact, we do. One of my last fellows who left to go to Mount Sinai in Toronto actually looked at the data from our center a comparison to theirs, which at that time they were doing the uterine balloon application. And it actually is a very effective way, but here's the problem. It took a significant amount of time out of the operating room to be able to do this. So there was the huge amount of time. They did have some complications with damage to the blood vessel, but I mean, it really depends on the expertise of the place and the ability to do this. So I think both are virtually comparable. The advantage as perceived is that you're not ligating the artery, but we do know from lots of data that it doesn't actually impact on fertility, and the collateral circulation takes over fairly quickly. So at the end of the day, in our article, we recommended just based on the fact that it was very quick and that not everybody has the ability to do IR, that we should be training people to do this so everyone knows how to do the internal iliac artery ligation. And most of the people are being trained in the tertiary care centers, and they go out to other centers, so they need to be familiar with the technique. So that's why they've switched to the ligation at the time of the hysterectomy.
I wanted to also ask you, is there any difference in the fertility preservation? A lot of people would, like to have another child, or sometimes I had a patient who had a stillbirth. So she wanted to obviously conceive again. So,
Actually, there have been a number of publications on this, and I had the experience myself when I was a resident. I learned how to do this, and I taught it to a staff person who had a patient who had a 24 years old and had a perforation during a therapeutic abortion. And we originally tried IR, but it actually didn't help. So I put it in the, I showed him how fortunately she came back 6 weeks later and asked for a tubal ligation. And the doctor said, no, I think we should wait. You're only 24. But then I rotated to another hospital, and there she was at 18 weeks, a number of months later, pregnant. And obviously she could get pregnant, but in fact, when you look at the literature, it really doesn't impact on fertility. I mean, obviously we'd like to avoid it, but
thank you. One sec.
I think fantastic talk, and I think that what we are to, as you rightly said, we need to train people. Just like FIGO has
yeah,
a obstetric fistula training, this is probably equally important to train our people in how to do it. Maybe one person at least in each of the main cities in the world, we should have the competency to do the ligation. That is very important, I feel.
I couldn't agree with you more. And in fact, like many surgical procedures, it's just a question of seeing it and understanding it and not being afraid. I think many gynecologists are afraid of the retroperitoneal space because we don't get trained to go there. And in fact, it is not a difficult procedure. And in Canada, it pays a lot more than the cesarean section, but nonetheless, it's easier than most cesarean sections, really.
Great. I think we have had a wonderful talk from Professor Nicholas, and we are looking forward to meeting you in Cape Town, where we are all just now in the other hall. Dr. Priya Somepillai, the assistant, Miss the Deputy Secretary of Scientific Chair, was telling that already 5,000 people have registered for the
Oh,
conference.
that's fantastic.
Yeah, so we are all looking forward to meeting all of us, and I would like to tell the audience that you should please register. There is time. There's nearly 40 days remaining, and the visas are easily available, tourist visas, so you can easily register for the conference, and it will be a fantastic, fellowship and a lot of science as well, and a lot of learning and a lot of exchanging views and mingling with cultures. So thank you very much. Pardon? One question more for him.
The last one, right? What is the anatomical basis for uterine artery ligation in PPH?
Okay, so the majority of the blood flow to the uterus at term, and it's 500 cc's per minute, is through the uterine artery. And in fact, when you go back to the origin of the uterine artery, that is exactly where the anterior division of the internal iliac artery is. So if you're going to clip the uterine artery, I think the logical thing is to move back, because then you get the vaginal branches, the other branches that interact with the other blood supply from the inferior mesenteric artery, and and you want to do it on both sides. So the logic is that will reduce the pulse pressure. It doesn't diminish the blood flow completely, but it diminishes the blood flow and the pulse pressure sufficiently to allow for clotting and diminution of the blood loss.
Okay, thank you so much. Just on a lighter tone, I had read somewhere yesterday or 2 days ago that there's a robotic pregnancy. Is that really happening? What is your, just to go on a different note, a robot carrying the pregnancy to term?
Yeah, so actually, that some Chinese firm is offering it like for $11,000. Maybe it will be possible. Maybe 5-10 years. They are quite dog sure about it with artificial intelligence and all. So we don't know. But
you never know. But I don't think robots bleed, so maybe there is some advantage.
But yeah, then, all this SDG goal will be achieved very easily.
Yes.
Okay, thank you so much. It was a wonderful lecture, and it was really nice connecting with you again, and hope to see you in Cape Town. Thank you. Thank you very much.
It's always wonderful to see you, and I look forward to that again. Thank you. Have a nice evening.
Thank you.